And the third big element of change that we face in the next few years is that in order to achieve the objectives of the white paper, then we are going to go through a huge reorganisation in the NHS. So primary care trusts and strategic health authorities are going. That's 160 organisations that will be abolished between now and 2013. And at the same time, GP consortia will be formed. It will comprehensively cover the whole of England. There will be a few hundred new statutory bodies to set up in that same time period. And we need to smoothly manage the transition from where we are now through to the very new shape and form of the service going forward. The changes aren't only at local level, of course. As you know, at national level, there's going to be a new national commissioning board for the NHS, and that will the government, the Department of Health, will allocate all the money to the commissioning board. It will be more remote from the Secretary of State and ministers, clearly, than the department is now. There will be a formal agreement between the department and the commissioning board for what success represents, how it will be measured and assessed, and that will be built into an accountability agreement for the commissioning board. Likewise, we'll go through the same with GP consortia. On the provider side, the new economic regulator that Callum mentioned, the new monitor will be very, very different from the monitor that we have now. Monitor now is the brand of foundation trusts. It's responsible for granting the licence, for assessing applicants, and then those that pass the test get the licence. It then runs a compliance regime so that when things start to go wrong, either with the money or in service delivery or clinical governance issues, then monitors compliance regime along with the responsibilities of the Care Quality Commission kicks in, and they get in there and they'll, if they feel it necessary, change the board or make whatever interventions they feel necessary to get things back on the rails. The new economic regulator will be very, very different. It won't just be the brand of foundation trusts. It will be responsible for regulating the whole of healthcare provision market. It will not run a compliance regime. It won't be stepping in to stop things going wrong or to correct them before it all collapses. Its role will be to deal with failure when it happens as a consequence of the market mechanisms that operate between the GP consortia, primarily as the commissioners, and the market of providers in the service. And that will be a fundamental change in the way the NHS works from where it is now. Most of the focus of the change, I think, in terms of the white paper and the discussion about the white paper and the responses that we've had to the consultation, has focused on the commissioning side. Clearly, the GP commissioning consortia is a very, very different way of working going forward. It's not to take or leave. It's not, if you fancy it, you can have a go at it. It's not an experiment. It is the way the world's going to be everywhere, and everybody will be part of it to operate as a commissioner. So there's been a lot of attention paid to that in the response. It's been the main talking point. Amit's just been asking me about the running costs allowances for consortia going forward. There remains a lot of interest in how that's all going to be set up, and we'll have much more to say about that when we put together the operating framework for the NHS for next year, and we'll be publishing that in the middle of December. So, yeah, the focus is on the commissioning side, but the changes on the provider side are, in my view, equally radical and equally significant. I've just talked about the role of the new regulator, and it's as different primarily because of what it won't do compared to what the existing regulators do, as opposed to what it will. But of course, we'll also head into an environment in which all NHS providers, all existing NHS trusts become foundation trusts, or don't continue to operate as they currently are. So we've a fixed date now for those trusts that aren't FTs. You've got to get their act together and become one, or they'll be taken over by somebody else that is, or run in a different way in the future going forward. And we talk about these things, dates like 2014 and 15 trip off the tongue, and we subconsciously think this is all a long way away, but believe me, it isn't, with the amount that we've got to do and change between now and 2012, and then on to 13 and beyond. The any willing provider policy that's contained in the white paper also fundamentally changes the world for providers. If you can deliver at the right quality and at the right price, then you are a player in providing of NHS services. And Amit and his colleagues and consortia around the country will be very keen to talk to you about the services that you offer, the way in which they're designed and put in place to meet patients' needs in the best way that commissioners seek to contract for. So I think we're heading into very, very radical times. And when you look at the extent of the change that we face going forward, and you look for lessons to other places who've done this, other sectors, other countries, this is large-scale change by any definition. It's as large as it gets in terms of the number of people, the amount of money that works its way through this system that we are turning on its head. And the evidence, when you do look at change and that's comparable in scale and size, and there's not much of it to find, is that 70% of it doesn't work. And the reasons that it doesn't work are in part, although not predominantly, that the vision wasn't clear and compelling enough. And I think that's, we've got a very good position on that. I think the white paper is absolutely clear. And I think the vision it articulates for the future, the opportunities it opens up for us to do better for the public and for our patients are immense. It's a fantastic opportunity that we have to take and make work. So I think that we have the vision that we need as part of the formula to succeed in this change. The bigger risk is how we manage the transition. Where this goes wrong in other places is that we know where we're heading to, we know where we are now, but we fail to find that right path that gets us from here to there without losing performance, without losing financial control, without being able to support our staff through this huge change process in a way that retains them, motivates them, and keeps them focused both on the delivery of today, but also the design of the future. And I think that the challenge of running these three things side by side, today delivery, we can't just stop and wait and say, we'll all concentrate on the new world and pick up the pieces in 2012. We have to keep driving on with the improvements and programs that we have. At the same time as that, we have to design the new world and think about how it's going to work. And that's not just a job in the department or at national level. Colleagues all over the country are working on their plans for consortia. And then the third bit is to plot the route from here to there and to manage it through in a way that we can explain and understand and carry people with us. So if this managing the transition is the key to success, we've thought a lot about, if you like, the guiding principles, the rules, call them what you will, that we need to apply together now, working from here through to 2012 and 13. The first is that we absolutely need to work together to design the new world. We wouldn't even pretend to do it from the Department of Health. It absolutely has to be developed, co-produced, to use the jargon, by all levels of the system, by all professions in the system, by people sharing perspective and ambition, their hopes and their fears in thinking about how we need this to work in the future going forward.